Hi, I'm Dr. Rena Azar, and I'm going to talk today a little bit about the different types of damage that can occur with bladder or bowel function. I'm going to focus on bladder function today, and we're going to talk a little bit about what symptoms are caused by what type of damage, and a little bit about how we repair that. So people have a variety of symptoms with bladders. People can have urinary urgency, frequency, difficulty emptying, slow stream, stop and start stream. In addition to that, bladders can hang and sag and cause pressure and discomfort. So when patients come to me and they have symptoms, we kind of have to sort them out a little bit. And the main cause of bladder symptoms is damage caused by childbirth. You can have damage caused by repetitive heavy lifting. There are some people that have poor connective tissue, meaning the tissue in the pelvic area is weak by genetics, really, and it can sag and give way and cause stretching damage to the bladder. So we're going to talk a little bit about how that shows itself. Generally speaking, we categorize symptoms as either anatomically related or neurologically related, because those two systems both have to work for us to get good bladder function. Bladder function that presents as stress incontinence, which is coughing and sneezing, and bladders dropping out of position are the main symptoms that we see with anatomic abnormalities. In other words, when babies damage the support structures, the fascia, ligaments, muscles, etc., that hold the bladder into position, when those get damaged, then the bladder doesn't function normally. It likes to be in place. It likes to be located in the normal area with normal pressures on it, a normal angle between the actual bladder and the bladder neck. And when those things become distorted from anatomic damage, once again, which occurs most frequently with childbirth, but also with heavy lifting, etc. And oftentimes damage will present a little later down the road. In other words, you might get obstetrical delivery-related damage and then have it present because it kind of falls gradually, and at some point it becomes critically low enough or shifted out of position enough that now you're noticing symptoms. It might be when you're 30, it might be when you're 50, it might be when you're 70. So, things that fix the anatomy are pessaries, which push things back up inside. Doesn't really give very good correction of a lot of other functioning of the bladder, but it does get rid of bulges. So pessary and surgery are things that fix anatomic abnormalities. And anatomic abnormalities, in other words, damage to the anatomy, results in urinary leakage with coughing and sneezing, because that's what makes that pelvic floor give. Bulges, heaviness, pressure, and those are the symptoms that surgery will fix, okay? But when people have abnormalities in their anatomy, you can also get the nerve endings damaged. So we have these little branchy nerve endings that run through our pelvic organs, and they come together, and they go up the spinal cord, and they talk to the brain. So when that occurs, we know that the damage from the nerve endings, or really actually damage in other parts of the body like the spinal cord or the brain. But once again, number one cause of neurologic damage tends to be childbirth, because it's so common and it is tremendously traumatic to the tissue down there. So it damages these nerve endings, and they can no longer send and receive signals to the brain and from the brain very well. So for example, one manifestation of bladder damage that is neurologic in nature is that a normal bladder can make it to the toilet on time. It tells the brain, hey, you've got an hour to find me a bathroom. That gives the brain plenty of time to find you a bathroom. Neurologically damaged bladders don't give the brain enough notice. Neurologically damaged bladders do not listen to the brain control. So normal bladder will listen to the brain all the way to the toilet, all the way till you get to the bathroom, all the way until you turn around, close the door, sit down, put your pants down, different order there, and sit down on the toilet and urinate. And so neurologically damaged bladders do not listen to the brain very well, and they oftentimes cannot make it to the bathroom. And this is a common symptom that people come to me. So once again, urgency and frequency are symptoms that are generally from neurologic damage. And so we have to look at other things to fix that. There's also another set of symptoms that goes along with neurologic damage that I think people need to be aware of, and that is that the bladder has to coordinate emptying. So the bladder is a balloon-shaped muscle, has all these fibers, and they contract at the same time. That's not a coincidence. This contraction of all the muscle fibers simultaneously, called synchrony, these synchronized muscle contractions occur because the brain coordinates that through its signals down to the bladder. So when that pathway of communication is damaged, then people will get poor emptying, slow emptying, emptying a little bit and then emptying a little bit again. And that emptying dysfunction is related to, once again, neurologic damage. Also, there are two muscles to the bladder that people need to be aware of. One is the balloon-shaped muscle that everybody visualizes when they think of the bladder. But there's also a neck to the bladder, and there's a ring muscle or a sphincter muscle at that neck. Okay, so that sphincter muscle, that ring muscle, has to contract while the balloon-shaped muscle relaxes when we're storing urine, and the opposite muscular action when we empty. This contracts and this opens, relaxes. So this is, once again, not a coincidence. It's neurologically coordinated. Bladder damage from the neurologic sense will make people have lack of coordination. So that can result in hesitation, where this doesn't open up when you're trying to empty, or intermittent stream, where you're trying to empty and this is opening, closing. Or it can result in slow stream because it's not opening all the way, or secondary voiding, where you empty a little bit and then this closes off, and you wait a little bit and then it opens up again and empties again. So that lack of good emptying is a neurologic symptom. And once again, this is something that an anatomy fix will not correct, okay? Now, I'm going to talk about the fix for neurologic dysfunction in a different video, but I'm going to say one other thing, and that is this. As with all things in life, there is a gray zone, okay? The black and white of dividing things into an anatomy problem versus a neurologic problem is not quite that distinct. There is a gray area. That gray area mostly results in people who have severe anatomy damage. In other words, if I look at their bladder and it's really hanging low, really low, I know that that is a bladder muscle that is on a lot of stretch, especially when you stand up, there's pressure. And there's a lot of stretch on those muscle fibers and the neurologic fibers. And so those neurologic fibers sometimes don't behave normally, and they can give frequency and urgency and poor emptying because of that stretch, the sagging, the pulling, and that's an indirect result of anatomy damage. So in people where I see a lot of anatomy damage, sometimes I'll say to them, perhaps it's better for us to fix the anatomy, look at doing some physical therapy to get that bladder muscle kind of waking up and get the communication between the brain and the bladder to normalize as much as it can now that the anatomy is normal. And we might not need to do a neurologic fix. Some people I look at, their anatomy looks pretty good. And I'm thinking, you know what, these symptoms of frequency, urgency, poor emptying, it's probably almost completely neurological. We may want to think about fixing that first or simultaneously with the surgery to correct the anatomy. So that is how that plays out. And when people have surgery and we do all the things that we can to fix the anatomy, sometimes we see the neurologic symptoms become a problem to the point where we have to deal with the neurology, or they were a problem before and they just didn't correct after an anatomy fix. And that's when we look at neuromodulation. And I'll do a separate video on neuromodulation.